why is this a cool data set? Because it's a massive cohort. It's 1,001 participants, and 30% of it comes from populations that are typically underrepresented in dementia research. That's huge. The number may sound small to somebody who perhaps doesn't work with dementia research, or to someone who perhaps is used to much more diverse cohorts in other fields. But actually, the fact that we're able to have complete results on such a huge variety of multimodal biomarkers from 1,001 people, and have 30% of those be from big populations we typically don't get to know anything about, and therefore can't help with our research, is actually a unique opportunity, and I can't stress this enough. You'll hear me use the word unique to describe this data set and this opportunity many times in my closing talk tonight, and I just wanted to make sure it's all prefaced with the reason why. So if we just take a quick look at our cohort, we've got 1,001 participants, and they are split rather evenly between 3 groups based on cognitive status. One is cognitively healthy, one is mild cognitive impairment, and one is Alzheimer's dementia, probable mild Alzheimer's dementia. You can see the specific numbers on the screen, but just to kind of say, I mentioned 30% of this cohort comes from populations underrepresented in dementia research, and I also mean that that's balanced between the 3 different cognitive groups. That's huge, again, so I'm just underlining that as we start our conversation. Now, this data set, I mentioned it's expansive, and I mentioned that it's a unique cohort, but I want to go into a little bit more detail as to why. What makes it special besides the number? And it's the kind of measures we have, repeated measures for every single participant. So you can see here that while it's a cross-sectional cohort, which means we only know about our participants at one single point in time, we in fact have 3 visits which collected cognitive performance, brain amyloid PET, so that's imaging, and also blood sampling, which provided results for blood biomarkers, cutting edge in research and in clinical practice. So you can see a little bit of this, about the structure of the clinical data. This will be familiar to everyone who has worked with this data set. So one of the resources we had made was a map to help all researchers navigate this data set. I will be mentioning that later, so just a little asterisk that we're going to expand on why this makes this data set a challenge for researchers who have the theoretical background but not the data expertise. But moving on for now, I wanted to talk about my research with this data set. I was interested in what predicts the risk of developing Alzheimer's dementia. This is where I'd normally skip you to a next slide that would look really pretty and it would have key information you would need to know about my project. But seeing as I have organized this event, which I will be confident enough to say is going along very nicely, and I hope you'll all agree, I've actually not had the chance to make very pretty, very well thought out slides, so you'll excuse me. But my work was about comparing the different ways of predicting Alzheimer's dementia. So there's a lot of published algorithms to make these decisions, and of those 6, I operationalized them as best I could. Operationalizing, here I mean tailoring, making sure that I have the right variables for this cohort to match the actual theoretical definitions they're supposed to reflect. And I thought, okay, I want to understand which ones of them are clinically useful, meaning that they meet requirements in terms of predicting cognitive status for those 3 groups that I showed you earlier. And I also wanted to explore what could explain the differences between them. Now, I have one thing to show you, one cool thing to show you, and that's this. What are we looking at here? We're looking here at the ability of each risk score. You can find them here. So we've got K, which is actually the oldest algorithm that I could operationalize in this data set. It's very, very well cited. Libra, we've got BDSI, annual ADRI, COG-D, and COG-DAD. Now, there's one I haven't mentioned. I will come back to this. Again, this is where if I had time, I would make this a very clear slide. But I want to show you that actually most of these algorithms are not able to provide clinically useful results. When I quantify what you see on this page, Actually, I find that most algorithms were very close to 50% chance of predicting whether someone belonged in the healthy group. This is whether someone was healthy or probable aging. Here we have whether someone was healthy versus mild cognitive impairment. Here we have healthy versus mild cognitive impairment or Alzheimer's dementia. And here we have mild cognitive impairment versus Alzheimer's dementia. So for each of these comparisons, we see that the oldest algorithms, K and Libra, are actually super close to the 50% line. You can see them here, and they tend to perform similarly across all four comparisons. So that's takeaway number one. Takeaway number two is that more recent algorithms, like ADRI, CogD, and CogD-AD, and I appreciate the caller might not translate very well in the room, so you'll have to trust me on this one. They kind of perform in between chance level and what's clinically useful. So here you can see them very clearly, they're kind of piled here. But what we see across all four comparisons is that the BDSI, that's the brief dementia screening indicator, which is aimed at professionals in primary care to be able to decide whether someone should receive screening for Alzheimer's dementia, is consistently outperforming every single one. BDSI, and we see that as the top performer in all of them. And in fact, it's the only one that meets criteria for clinical useful in terms of its performance for the healthy control versus Alzheimer's dementia comparison. That's huge. We have all of these algorithms, and only one of them is clinically useful. So our next question was, what makes it useful? And I broke down all the factors that were included in them. And one factor that was not shared between the BDSI and any of the other ones was functional independence. Functional independence in daily life can look like many things. Some people, it depends into two categories of activities, right? We've got basic things like going to the bathroom and drinking water, being able to swallow. But we also have extended activities of daily living. Those are instrumental in actual independent living. Those can be things like being able to move around safely and manage finances, remembering things. When I took out the functional independence from the BDSI, it immediately dropped to the level of the other factors. Now, I don't have time to tell you more about what this means, though I really wish I did. But I hope you'll trust me on this one, that this is a very, very cool finding. It's definitely not something that we were expecting based on the literature. And if you're interested, keep an eye out on my coming publications on this, where I'll expand on what this also means about how we measure risk of dementia in clinical trials and in clinical practice. So that's me.
Wonderful. Thank you very much. So the project which we submitted to Bio-Hermes data, we called Risk Prediction of Alzheimer's Disease using multimodal data. So what made me interested in analyzing this data set, because we had a very recent, very similar study, measured very similar variables in our Welsh dataset, which is Alzheimer's disease cases and controls. We measured biomarkers, thanks to UK DRI, who supported to measure the biomarkers to financially that particular aspect of the study, and we had genetic data for the same people. So in our publication, we've done very similar what we've done in the original Bio-Hermes dataset, and my question was, why again, in this Bio-Hermes publication, they see accuracy of prediction Alzheimer's disease status, as I read it, by biomarkers with accuracy about over 80%, even 90%. In my analysis, it was 70%, 65%, so I wanted to answer that question. And I also wanted to include a bit more information here, because in Cardiff we are famous to do genetic studies, so I wanted to include also more genetic information into prediction model here, and potentially, if I had time, expand it more to another data types. So that was our, this is why we applied for access, and thanks again to ADDI platform and to the Bio-Hermes data holders who allowed us to do that analysis. So what we've done, we've taken genetic data, and of course, first of all, we looked at people who had biomarkers, case control status, and we also looked at their genetics. So we had only 945 people who were, according to our quality control criteria, not our, but I mean standard quality control criteria, who passed the QC. Out of them, 790 we had Europeans, 103 African and 9 Asian. And that is a genetic plot when we combine BioHermes data with 1,000 genome data and plot them together. So blue dots here are people from BioHermes dataset, and now yellow people are from African population of 1,000 genomes, red ones are European, and green one are Asian. And basically, as you see, genetic works. It was unexpected according to BioHermes data and genetic data. Population-wise, we were fine. So we were happy about this. So what we've done next? We calculated polygenic risk score using the latest approach, which is called PRSCS. We can do all of them, but we can argue which one to use, but that's what we used. Just for saving time, I will not go to details. And we also looked at summary statistics, European-based summary statistics from genome-wide association studies for Alzheimer's disease and intelligence. Why those? Alzheimer's disease, obvious. Why? Because we are looking at Alzheimer's disease status, and intelligence we chosen because we had cognitive scores, so we wanted to see association of that score, and if that intelligence-based polygenic risk score improves the accuracy of the analysis. Biomarkers, we've had a lot about this already, so I will not repeat myself. p-tau 217 was in the pool as well, so we looked at that. And the phenotypes which we looked at, again, Alzheimer's disease and MCI controls. We looked at depression, although I'm not presenting that. We looked at amyloid PET data. I will talk about this. Of course, we looked at age and sex and cognitive measures. And analysis which we performed, we wanted to separate cases against controls to find the best prediction model, cases against MCIs, and also later, when I understood why we had such a big discrepancies between BioHermes data and our results, we also looked at AD who are also amyloid positive and controls who are also amyloid negative. So we looked at those two. That's the demographics. I will not stop on this much, and it's lots of information, and that was already mentioned before. Just to say to you that, as expected, the age of cases was a bit older than age. Cases were slightly older than controls. As expected, the MLSC score was lower in cases as compared to controls, etc. So all that information made sense to us, so I will not stop on that for too long. Then we looked at biomarkers, and we basically put biomarkers correlations first in AD, Alzheimer's disease cases, in MCI, and in controls, and in European and in African population. So from this plot, quickly, if you can see, they again make sense. For example, the first, does it go point? Yes. So this, you see this high correlation between AB40 and AB42 biomarkers as expected, high correlation between p-tau 17 and 181 as expected, and the patterns pretty much the same. What is interesting, perhaps p-tau is not correlated with AB40, practically no correlation, again, showing that biomarkers, some are correlated, whatever expected to be correlated, and those which are not, they perhaps reflecting different aspects of pathology development, so all good here. Finally, first let's start to look at the results. What we observed here, if you look at the cases, results for cases, that's for MCIs, and that's for controls, and that's an European sample. So what we see, association of biomarkers with age. So in Alzheimer's disease sample, so we have biomarkers are associated with age. In MCIs, they are associated stronger, but the strongest association is appearing in controls, which with the biomarkers with age, which means that the older you are, the more neurodegenerative processes happening in your brain, so they're in the same direction of effect size. And also that means that probably we do, because controls are slightly younger, we have some people which are at the stage of the prodromal of disease, but which is not have been made into the MCI or AD plot so far. Then what else? Then we looked at prediction accuracy. So I mean, I would not look at p-values here because the sample size is different, but perhaps AUC prediction accuracy is the best to look at. So AD cases versus controls. Well, finally, I'm getting again low accuracy here, not 80–90%. And then I understood that in the paper, they're looking at predicting amyloid deposition, where we are looking at clinical diagnosis of cases and controls. And therefore, so clinical diagnosis does not equal to amyloid deposition. So we've seen cases, looking into the data more, we've seen cases who are amyloid negative, we've seen controls who are amyloid positive according to classification. So that's all good. So in terms of clinical diagnosis, that's the prediction accuracy which we've seen. P-tau gives us the highest one, cases versus control. When we look at AD versus MCI, it's getting lower because they're getting closer, obviously. And when we look at looking AD and amyloid positive versus controls and amyloid negative, the accuracy is very high, 93%. All makes sense. We also run model when we combined all biomarkers together, and 75% was p-tau, 79% accuracy was when we combined everything together. And when we run stepwise regression, checking what of the biomarkers are useful for prediction statistically, all of them needed into the model to achieve that accuracy. We've done the same in MCIs. Again, 67% was p-tau to 17, 71 overall. And obviously here we had a fantastic accuracy, 95%, that'd good. That's something I really like to see. I wish all my results were like that. We did the same in African population. So previous slide was about European population. And also again, we see the highest accuracy with p-tau 17, not as 90, not as 80%, not even 75, 64 only. But when we combine again all biomarkers together, the accuracy got better. So p-tau is not as predictive in African population, but again, combining everything, we are getting the accuracy quite nicely, over 80%. Now, back to genetics, because that's what we are good at. We calculated polygenic risk scores using AD summary statistics. We excluded ApoE region and looked at accuracy of prediction by PRS without ApoE, intelligent PRS, and ApoE alone. So the accuracies are not as fantastic, cases against controls, 58%, 56%. With or without ApoE PRS doesn't really matter, you see, it's a slight difference. Intelligence quite well predicting that as well, PRS. And ApoE alone is higher than either of the PRSs. What does it mean? It means that in the PRS, we are picking up some noise, and ApoE alone is predicting better than the PRSs with or without ApoE. Now, when we look at amyloid positive negative status, look here, ApoE, of course, improves the prediction 74% with ApoE alone, but AUC is not really improving when we look at the polygenic risk scores, well, for this disease anyway. African population, even more interesting. Look, in African population, ApoE is not predictive at all, 50% accuracy. But PRS, based on trained on European GWAS, actually similar accuracy as in European population. So we are picking up something with PRS useful, and although the values are not fantastic, but it's still better than that. I was actually surprised. And when we again took all these scores together and biomarkers, so again, we've taken biomarkers, genetics, we had 81% accuracy, over 80%. Similar results which we get in the Welsh population. And even in African population, we achieved 82% accuracy when we analyzed everything together. Yeah. Yes, we ran a couple of GWASs, because if clinical diagnosis is not very good, why won't we do diagnose disease or run GWAS separately? We've seen ApoE in none of the analysis, ApoE was significantly associated. Oops, sorry, it's already summary. What we observed that we have a couple of interesting results for AB40, some genes which are making sense, and they are, in fact, and here we have, in fact, we do have, it's not ApoE, it's something else. Anyway, so we do have finding some interesting genes which are new. So in summary, when we have cases versus controls accuracy with p-tau, 217, 74%, all biomarkers 79%, when we combine it with genetic, 81%. Well done us. AD versus MCI, all biomarkers 71%. Amyloid positive N case, clinical case, amyloid negative clinical control 95%. And also we can run GWASs, and we do find xenobite significant SNPs, and the new genes make sense because they were reported before as relevant to neurodegeneration. And in work in progress, what we are doing now, we now, with collaboration with team from LifeArc, we are trying to combine our data plus proteomics data to improve prediction even further and see which of the predictors are the most important. Then we also need to understand biological evidence for the novel loss rate. Yes, so we need to, I said that already. Then we want to verify robustness of our prediction accuracy. Actually, we need to run some cross-validation analysis here too, because that was based only on one analysis. We need to write a journal publication, and I would like to ask community to let us get access to the data, or at least not delete our data after the deadline, so we can publish a paper. I was very quick, but I'm very happy to answer questions.
All right, thank you all so much for the opportunity to present today. My name is Dr. Megan Kirk-Chang. I'm a senior researcher in mental health and behavioral medicine at Oxford. As you can tell, I'm not from this part of the world. I am a proud Canadian, and this project represents a very exciting training and development opportunity for me. It's my very first cohort analysis project. I'm an interventionist by background, so it's been an absolute pleasure to work with several collaborators across the UK, particularly my colleague, Dr. Joseph Kwan, who was a mentor with these statistics, as well as Callie Mavramati from Glasgow, who you know quite well. And then just thanking my funders for the fellowship opportunity to be here today. So I think it's really important as researchers to take a step back sometimes and not be so focused on our metrics and this publish or perish mentality. So I want to start off this presentation by explaining a bit about my why behind my interest in looking at a life course perspective of mental illness, implications on cardiometabolic risk, and subsequent cognitive decline. This is a picture of my family, and about 7 months ago, our family of 4 suddenly became a family of 3. We unexpectedly lost my sister at the age of 44, and right in the middle of this Bio-Hermes dataset. And this has been a huge shock to our family, but has motivated me as a researcher to continue this work. My sister struggled with mental illness, and I could see throughout my life course the cardiometabolic risk that she was exposed to because of the mental illness. And then I was thinking about, well, what happens later on in life? So this is really dedicated to her today. So my NIHR ARC Fellowship Program of Research looks at 3 different projects: a systematic review, a cohort analysis project, and potentially a proof of concept trial. So the field that this really lands in is an emerging multidisciplinary field known as metabolic psychiatry. You may have started to hear this phrase. And what I'm really interested in is this interrelationship between mental illness, comorbid metabolic dysfunction, and how that leads to co-occurring physical conditions. This really looks at identifying common causal risk factors or shared biological mechanisms between mental illness and metabolic dysfunction, so that we can actually explore novel and innovative interventions that optimize metabolic function, such as improving inflammation, optimizing energy pathways, and looking at insulin resistance, so that we can simultaneously address multiple long-term conditions where mental health and physical conditions are key. And what I love about this is that it's exposed me to a multidisciplinary team of researchers, from dietitians to social workers to clinicians to psychiatrists, and I absolutely love this field. So I'm preaching to the choir here, but since the pandemic, rates of depression and anxiety have rapidly risen. We were sitting around 300 million cases each across the globe, and that's increased by about 30%. The prevalence of serious mental illness like bipolar and schizophrenia sits around 1 to 2% in the population. I do think this is underrepresented due to stigma, due to gaps in diagnostic criteria, because on average it takes approximately 10 years for someone to receive a proper serious mental illness diagnosis. So I do think this is severely lowered. People living with severe mental illness are at risk of dying 15 to 20 years earlier, and 2 to 3 deaths are from comorbid physical conditions that can largely be prevented through modifiable behavior change interventions. Now, what surprised me coming to the UK was knowing that dementia, instead of cardiovascular disease in Canada, was actually the leading cause of death here for the last decade. So this made me very, very curious. As you know, the NHS costs are expected to triple to over 60 billion by 2040, which, coming from Canada and knowing the healthcare system there, we're just not prepared to handle this burden. And then folks with dementia are at increased risk of multiple long-term conditions. We know there's a bicausal relationship between cognitive decline and mental conditions, for example. So the work that I've brought over from across the pond is really looking at this life course model of exposure to early life adversity, trauma, and chronicity of mental illness across the life course. We know that there are genetic changes that can happen when a young child is exposed to early life adversity. And we know that there are very real biological changes in our physiological makeup when we don't address or properly address mental illness across the life course, leading us to an increased risk of cognitive deficits, disease, psychopathology, and social challenges as well. So I'm really interested in honing in on the common causal risk factors, as I mentioned, and exploring this interrelationship between these variables. And dementia, just briefly, is a brain energy and metabolism impairment where glucose uptake is diminished by 20 to 40%, as well as the beta amyloid plaque buildup and neuroinflammation as part of the disease pathway. So what I want to present to you is the preliminary results from our Bio-Hermes data set. And this was looking at bivariate associations between depression, cardiometabolic risk factors, adverse lifestyle, and plasma AD and cognitive function, stratified based on cognitively normal, mild cognitive impairment, and mild AD. This was to inform exploratory stepwise linear regressions, and then we're just at the stages of refining and informing the model structure from these stepwise regressions for a future structural equation model. Okay, so I'm going to skip over the descriptives because a lot of you have done this already today. So we do know that there's differences across the cognitive status in age, sex, and education. We also know that the proportion of people with mild AD report high blood pressure. There are significant differential effects of BMI and overweight obesity, which looks like it's declining across increased cognitive impairment. And then alcohol use was significantly higher in cognitively normal compared to the mild AD, and no difference with smoking use. Depression, we see, even though depression wasn't a criteria for inclusion for Bio-Hermes, we do see that there's more prevalence in depression scores above 4 on the GDS-8 in mild cognitive impairment, and higher GDS scores overall in MCI and mild AD compared to cognitively normal. We do also see the expected plasma biomarkers elevated in MCI and mild AD, and cognitive performance and functional impairment as expected. So what I want to hone in on here are the bivariate correlations. So first, looking at depression and its relationship to plasma biomarkers. So we actually binarized depression to look at people who met a score of 4 and above compared to those that were lower than 4. And what we see here is a significant relationship in elevated plasma biomarkers based on GDS score, which is what we expected. In terms of cognitive function, we see a significant reduction in MMSE in those that reported higher than a score of 4, and we see higher functional impairment as well. High LDL seem to have an interesting relationship, possibly due to the cross-sectional nature of this, where those that had a high LDL, which is a risk factor, actually showed lower plasma biomarker circulating p-tau 181 and 217. High blood pressure was associated with cognitive function. We see relationships there, as well as overweight and obesity seem to have an inverse relationship that got me curious. And then past or current use of alcohol also had an inverse relationship as well. So that was very interesting. So moving now to the linear regressions, our base model, where we added age, sex, and ethnicity, showed that 2 of the 3 variables were statistically significant in predicting MMSE. And these 2 predictors explained about 13% of the variance in cognitive score, which some people might think is low, but when it comes to human research and how different we all are, I like to see something at least 10%. So this was kind of nice to see. Then working through the stepwise regressions and accounting for collinearity, I'm presenting one of our final models where we see 7 predictors emerge as explaining 37% of the variance in MMSE score, which jumps up by about 25%. So we still see age and white ethnicity holding strong here, but alcohol use, depression, LDL, p-tau217, and FAQ have now come into the mix as well, with interesting relationships. So there is an apparent, just interesting with alcohol, that higher alcohol use was associated with higher MMSE scores. So I am picking my brain on explaining that at the moment as well. Then looking at interaction effects, we see that there was a significant interaction between depression and FAQ, basically suggesting that depression on its own is not a predictor. You can see that it becomes non-significant when we explore the interaction effects, and it depends a lot on functional impairment, which goes quite nicely with Callie's presentation just a short while ago. Depression becomes relevant when higher functional impairment happens, and FAQ remains a standalone predictor even through the interaction effect. So it's a very important variable to consider. In terms of where we're at now, I wish I could be a little further along, but as I said, I've had quite the year. We are looking now at building our model for our structural equation model, where we can simultaneously examine the relationships while adjusting for confounders. And so we'll be testing both direct and indirect effects, and this will help us confirm if the relationships hold beyond the simple regression models that I've shared with you. And this really is to be a more theory-driven approach to understanding cognitive impairment and Alzheimer's pathology. So just briefly, the implications of the findings, we see that depression, cardiometabolic risk, and lifestyle are differentially associated with plasma biomarkers of Alzheimer's and cognitive function. There's a disproportionate cognitive risk in adults from ethnic minority groups, which is really important for my work as a behavioral interventionist to maybe streamline some interventions to ethnic minority groups at higher risk. There are paradoxical findings on lower BMI and AD biomarker burden, which contradicts prior research, so expanding on that a bit more. And blood-based biomarkers, based on these findings, are linked to both cardiometabolic and mental health risks. Knowing this can help improve early detection and intervention strategies, and introducing plasma biomarkers, as we've seen from the presentation before, into behavioral interventions and clinical assessments as an objective measure of cognitive health should really be considered, namely p-tau217, neurofilament light, and MMSE. And this is a really inexpensive alternative to brain imaging, as was discussed earlier. One of the things I noticed with the NHS Health Check is that there's no mention of mental health assessment or a structured cognitive standalone health assessment as part of the free NHS Health Check. So my work moving forwards with the ARC is exploring a mental health and neurocognitive bolt-on to the NHS Health Check, potentially looking at blood plasma biomarkers. So moving just very quickly, looking at modifiable behaviors that influence metabolism and how we can address the findings moving forwards. I am proposing a future multi-component trial looking at a ketogenic diet plus the addition of exercise to act on a downstream mechanism, so insulin resistance and inflammation, to hopefully prevent and reduce the risk of cognitive decline. So at the end of my presentation, and appreciate the time very much, essentially, we're going to explore more of this further and have a nice publication at the end. I just want to thank everybody for holding space for that presentation virtually, and you can contact me if you've got any further questions below.
Thank you very much indeed, Atticus. I think you alone have managed to remain within time. If anyone has a very quick question before you run away. But it would appear that they're all, oh no, we do, excellent.
So just one more comment, which is very actual thing seen and talked about. When I looked at individual cytokines, the Bio-Hermes dataset had come out individually significant, when you put them all together, quite a few of my favourites all dropped out in a more complex model. It's very sad to lose at IL-17 examples. So,
It hurts, I know.
Sorry?
Again, when your favourite drops out, you're saying, well, is there really a signal here?
Model, like them all together on the single model.
Yeah.
Probably good chance you might lose them all. Something interesting.
I guess that's just a rule for life. There's a danger on having too many variables. If I could rephrase your question, we might have felt there would be a kind of cluster of inflammatory related cytokines that would all go up together. I feel like they haven't, especially. If that's what we were thinking would happen, it hasn't. I don't know if that effect with interleukin-6 is real. I don't know if it'll be replicated when we do the RAP data set. It's kind of intriguing. I don't think this sort of rules out the notion that inflammatory markers could be useful in this field. It's quite a murky field. There are things we do know about how you diagnose someone who presents with dementia, but an awful lot we don't. And it would cost a lot to find it out. We're not going to do PET scans on them all. The notion of having a blood panel, and there are these new multi-analyte panels coming along with Olink and Alamar. I think 5 years from now, it may well be worth doing those multi-analyte panels for the very reason you sort of imply.
Okay.
Thanks.
Thank you very much indeed. Okay, wonderful. Thank you. We have progressed through 4 fabulous presentations about work that's been done with the BioHermes data sets. Atticus has segued nicely into ideas of different data sets that are out there and mentioned my favourite subject of all, MRI scans, so that's been wonderful. We now have the pleasure of welcoming Matt Clement, who joins us. He's going to be talking about the ADDI data set in his role as Director of Partnerships and Scientific Strategy within the ADDI initiative. So, Matt, welcome.
So I apologize for not being able to be there in the room with you, but let me start by thanking Terry and Callie and the Brain Health ARC team and colleagues. In addition to the GAP team, I believe Lynn Hughes is there with you in the room, and I think John Dwyer is on the line with us. Without all of their efforts, this challenge would not have been possible, and we were really thrilled to partner with all of them to make this happen. I've really been blown away by the great work that's been shared thus far, and so I'll try to keep this segment brief since we're really here to talk about the science today. But I did want to mention a few things about the Alzheimer's Disease Data Initiative. Many of you there are familiar with some of the infrastructure that we provide, but I can tell you a bit more about where we started out and what our larger goals are. So bear with me here. So I'll start by mentioning that the AD Data Initiative is a coalition of organizations that have come together to accelerate new discoveries, informing the development of diagnostics and treatments for Alzheimer's and related dementias by helping to further enhance the data ecosystem for a global community of researchers. And you can see our current list of coalition members there on the right side of the screen. We envision a world where a user can seamlessly transition across multiple platforms which enable access to a broad spectrum of data sets. And we're pursuing that by increasing interoperability with existing data platforms. I know that Dementia's Platform UK is represented within the group here today. I think Simon Young's on the line, or was earlier. And DAPE UK is one of several platforms that we're now interoperable with. And we're doing this to help enable deeper analysis of more data by a broader community of researchers and scientists. Our second aim here is to encourage more sharing of dementia-related data across academia and industry and helping to unlock more data sets that are not currently shared. And we're also, in the third aim here, promoting a more enabling environment that helps support and encourage researchers to participate in more data sharing, collaboration, and the sharing of lessons learned with the larger community as a means of helping to invoke some cultural shifts in this realm. I don't think I probably need to introduce the AD Workbench to those of you who have been utilizing it, but I will say that early on, our coalition supported the pursuit of creating in air quotes, an interoperability layer that we call the AD Workbench. And it's a free, secure, cloud-based data sharing and analytics environment. It offers a set of features for discovery, querying, and requesting of data sets. There are now over 100 data sets listed in the AD Discovery portal that are searchable and requestable. And some of those data sets are surfaced, as I mentioned earlier, through interoperability with other platforms, DPUK being one of several. And the AD Workbench also provides, as you're well aware, private workspaces to support researchers in performing analyses. And that is provided at no cost to the community. So maybe I'll pivot a little bit here and talk a bit about some of the bigger goals and activities that we're pursuing as an initiative. So as discussed, we're working to make more dementia-related data discoverable and accessible by the global community. And within this larger framework that's depicted on this slide, we're working to unlock data sets, as I mentioned, not currently shared with the community. But we want to do this to help address, find the right data sets to help address several key research questions that I'll mention in a minute that we feel need to be pursued, or many of which are already being pursued in the field. Some of which were already have been touched upon by many of the groups that have been presenting already today. So I'll walk you through some of the activities and levers that we are using to employ the activities to address some of these questions. So here's our list of priority research questions. We had originally put together an initial list back in 2018 when our coalition members first got together. This was prior to the public launch of the AD Data Initiative. But in the past year, we've taken some time to revisit these questions and revise them in consultation with our advisory board, other key opinion leaders, and members of our community. And this is the list that we've come to. I'm not going to go through them all, but if you want to use that QR code on the slide, you can find the list on our website. And as I mentioned, many of you have already been addressing some of these questions. We further categorize these questions into different theme areas. So that's 8 different theme areas in blue, and then we feel that there are a couple of cross-cutting themes there over on the right-hand side that go across these different areas. I'll briefly mention some of the levers that we're using to pursue these questions. And if you look up at the top left of the slide there, you'll see that there are data challenges, fellowship programs, and research collaborations that we're utilizing to address these questions and help advance science within the community. Data challenges, of course, this is one of them. And I'll mention briefly that our fellowship program, the first cohort of which launched in 2023, includes 7 fellows, and that was a 2-year program. So the fellows are currently in their 2nd year. I think Sammy Donzo is actually one of the speakers that's scheduled to present later today. And Sammy is one of our William H. Gates senior fellows. And we'll be announcing a 2nd cohort of fellows in a couple of weeks. That group will be much more focused on advanced AI approaches to approach these research questions. The 3rd lever that's listed here is touches on research collaborations, many of which are depicted on the right side of the slide, where these partners are engaged with us or enabled by our infrastructure on activities to address some of these questions, as well as activities that will ultimately make data more shareable with the larger community. You'll see there among those logos is the Bio-Hermes logo representing our ongoing collaboration with the GAP team. And maybe I'll just wrap up here with my short segment to mention that there is a 4th lever that we're pursuing to address these key theme areas. And we're referring to that as quote, driver projects. These represent a means of standing up targeted and dedicated multidisciplinary scientific consortia and teams around the globe, which will answer these priority research questions, and in many cases will will be unlocking data sets that are not currently shared in order to address some of these questions. They're represented over here on the right, the four projects that we're currently in the process of pursuing. We're looking at BACE inhibitors, revisiting some of the industry trial data that to explore the utility of low doses of BACE inhibitors and what that could perhaps do to help delay the onset of AD as perhaps as a primary prevention. We're looking into gender and sex-based risk of dementia, evaluating why there is this disproportionately high incidence of Alzheimer's among women, looking also into rates of progression, as well as heterogeneity and subtyping. So maybe with that, I'll stop, and if there are questions, I'm happy to answer them, but I would like to give the floor back to the group in the room to be able to get some coffee and have some good, meaningful scientific discussion, rather than having me talk to you about infrastructure and this sort of thing. But we really are pleased that you've engaged with us and our infrastructure, and I hope that you'll continue to do so beyond the activities of this challenge here today. Thanks.
Matt, thank you very much. Thank you so much for setting the scene as to how BioHermes fits in with the wider AD platform and highlighting the opportunities that are available to researchers from across the globe, and including Scotland within that. Thank you, that's been fabulous. We are going to take you up on your suggestion and make sure that there's some coffee for the final session of today. But we're incredibly pleased that you were able to join us today. Thank you so much.
What I want to do is just introduce the people that really made this happen, the people that gave us the data set, and that's the Global Alzheimer's Platform Foundation. You're going to hear from John Dwyer, the CEO, but in the room here, we have Dr. Lynn Hughes, who's the Chief of Staff. Over the course of today, there's been a lot of questions about GAP, about BioHermes, about BioHermes001, about availability of data. So Lynn's going to say just a few words about that, and then I'm going to introduce John, who'll tell you a little bit of his reflections on this whole process. But Lynn, do you want to say a few words?
Lovely. Thank you. Good afternoon, everybody. It's really nice to be here. I've been involved from the GAP side, from concept through to the end today. And it's been fantastic to see all the posters, abstracts. Amazed at how many people can count to 300 in the 300-word abstract requirement, and how many people can't. There were a few, but we had a few questions. One of them was about the database. As you know, we're closing access to it. This database was embargoed for 18 months after last patient in and database lock. That embargo finishes on the 1st of July this year. At that point, all these data will be publicly available to everyone on request. So we have a little bit more time with the database, and then you can all have open access to it on request. Request a GAP, please. And if that changes, I'll let Terry know, and we can let you all know. The other thing that you might be interested in is BioHermes002. BioHermes002 has recruited 1/3 of its patients already, with over 300 or so subjects in the trial. Exactly the same design, 3 cohorts. But it's not a cross-sectional study. We've added in a longitudinal arm out to 2 years. We've added in single shell and multi-shell diffusion MRI to look at white matter, microstructure, and small vessel disease, so we can start looking at vascular dementia. We've upped our requirement for underrepresented populations. We've added in tests for alpha-synuclein. We have now got hundreds of biomarkers in this study, in different platforms. We've got lots of digital tests. We've got 3 sets of proteomics now, and all other omics, which I actually thought, when I heard the word transcriptomics, I thought it was a made-up word. My son told me it wasn't, and I'd read his PhD, so why didn't I understand it? Apparently it was all on transcriptomics. But we have a lot of omics and full genotyping. We're going to have a look at what we can do with these data. The data, again, will be embargoed until 18 months after database lock. That is 2030. That is obviously too long. So we'll be working very closely with Terry and the team to see if there's an option to continue the collaboration and what we can do. GAP and non-for-profit, we are here to push the field forward. And there's no point us holding on to data for 5 years. It'll be out of date by the time others have access to it. But we also have to honour all our partners who are funding these projects and who have to have exclusive access for as long as possible to the data on their products, on their blood-based and digital biomarkers, so they can interrogate the data and put in for approvals as they want. So we're trying to tread that fine line, the balance between scientific requirement and need and honouring our biomarker funding clients. So that's all I wanted to say. You're going to hear from John Dreyer next, who's my friend, my boss, and he's the leader of GAP. This was his idea. It came to him, and then we implemented it. And many thanks to Terry and Callie, because honestly, they've done the most brilliant job ever. So thank you. And I'll
Thank
leave
you
you
very
to
much,
John.
Lynn. You're very, very kind. So we're now going to hear from John Dwyer, the CEO of the GAP Foundation. Picture the scene, summer in St Andrews. Frank Gunmore, who many of you know, has a summit that brings together the movers and the shakers in the dementia field. And John was there, and he said, I have this data set. I will make it open to you, but I'm setting a challenge. He used the word challenge. He said, I bet you can't have this available by the beginning of the year. And we like a challenge. So we said, bet we can. And we did. And today is evidence of that. So, John, looking forward to hearing some of your reflections on GAP and on the data challenge. John, over to you. Thank you.
So, Terry, I'm hoping that you folks can see. You can see me. I've never looked better. I've never looked better on a wall than I do right now.
We can see and hear you.
Great. I want to tell all of you that it's really an honor to be able to speak at this event today. Terry doesn't, as typical, understates the enormity of the effort that it took to pull this all together. But I would like to give the audience just a couple minutes of background on who we are and how we came to get here, because it explains some of the underlying themes that you've heard and what you will see from us as your partner in the near future. We were created actually in 2015 at a meeting at the New York Academy of Sciences, where a number of your colleagues in the research field, industry, and Alzheimer's advocates got together and asked the interesting question of what is the most clearly unmet need for the discovery of a therapy or cure for Alzheimer's disease. And they were, I believe, a little too bullish on the likelihood that the science was going to mature. Remember, this was 2015. They said the amount of time that it takes to conduct an Alzheimer's study, the failure rate, and candidly, the lack of rigor for making these studies effective. There was a lot of work to do process improvement and re-engineer how clinical trials were conducted. I am not a scientist, so you'll forgive me for any misstatement I might make. Last time I took a biology course, your fellow countryman Darwin was getting off the boat. So I have a great deal of respect for scientists and clinicians, but I am hugely impatient as a patient advocate. So it was with that thought in mind that they offered me the job to be CEO of GAP in 2016, and we've been hard at it ever since. So I would like to correct the record and say that in the summer of 2023 that Terry alluded to at Frank's gathering up in St. Andrews. By the way, the only thing I own with anything Scottish on it, something I plan to add to the wardrobe, is the St. Andrews vest, hence why I'm wearing it. The fact is that I went to this conference and it was terrific. Each and every one of you are bright, enthusiastic, highly energetic researchers, but there seemed to be a constant theme. I could be wrong, but my recollection was, before I spoke, that there'd been a list of complaints, or more accurately, shortfalls in the raw material that the Scottish and UK research community had to make inquiries of and ask scientific questions and seek solutions. I found that you haven't seen plaintive, you haven't seen sad till you see Scottish researchers with a tear in their eye. So I decided on the spur of the moment, which is the nature of our organization, that we would, it was within our power to do, we would break our protocol and make available to Terry and Frank and Callie, Sheena, Stelios, Millie, all of the people that came together, if you in the UK could move quickly, that we would present and make our data set available more than a year and a half earlier than the rest of the world would have it. Terry said absolutely we can do it. Having that promise was all it took for us to make good on our commitment. And obviously we couldn't have done it without our partner, Matt and ADDI, to further enable your research efforts. I am so grateful for all your hard work. The speed at which you did this is unparalleled. Trust me. I've now been in the field 8 years, and that's long enough to know. The rigor and quality of all your work is remarkable. And some of the efforts here never even came up in our discussions about how we might interrogate our own data set. And I could go through the presentations I saw today and point that out. The one that I can't not comment on was the one about depression and it's the signal that it was given. I also like the interleukin-6 cytokine presentation. It's one that's also near and dear to me. But that kind of creativity and the rigor with which you folks went after it is a compliment to you, obviously, but also will elucidate our data set and the work that's going to be done with sister sets like RAP, like ADNI, like ABLE, and with the help of ADDI, we can really supercharge the inquiries that you all undertake. This is what is so special about collaboration. This is what's so special about not sitting around and perseverating over how to get to the data, but catalyzing access and pure clinical scientific analysis. That is what we are all about. You have met the challenge. Each one of you are a challenge winner to have been able to bring this across the goal line in 1 year. Terry lit the candle on February of 24. And we're closing, we closed it, and you folks are presenting in March, but we closed it in February of 25. Some of you are very young researchers. I can tell you, your field does not do much in a 12-month sprint. And that alone makes this a remarkable event, even if the science wasn't, and the science was terrific. So, a couple just afford me the privilege of making a couple observations to stimulate young scientists towards ancillary activity. One thing, Lynn, who by the way also deserves an enormous amount of credit, keeping our side of the house disciplined and on time responsive and helpful, required her iron hand. And so much of the good that you are realizing here are because of Lynn's management skills and her refusal to take no. And I'm very grateful to you, Lynn, for helping us be good partners in this collaboration. What I did want to mention, just one thing to all you researchers, is that in the context of what we're doing in BioHermes2, there are some clues in BioHermes1. In BioHermes2, we have undertaken, in partnership this time with the UK, we have 4 UK companies that are in BioHermes2 through the IUK program. Really terrific, very thrilled to have UK participation and the entrepreneurs of the field as part of our program. But embedded in BioHermes2 is, as Lynn mentioned, is a highly focused effort, not to just look for AD dementia, which GAP thinks is only about 30 to 35% of the cases in the United States are actually amyloid tau neuroinflammation induced dementia. We think the other 60 to 65% are something else. As our colleague who looked at the interleukin 6, for example, vascular dementia, when I push your colleagues in the neurology field against the wall a bit and say, if it's not Alzheimer's disease, what is it? Well, it's vascular dementia. How do you know? I'm a trained attorney, I apologize, but I can tell the difference between a crisp answer and a not crisp answer. We need to understand that. Why is it that 40% of Alzheimer's patients have elevated alpha-synuclein? Now, the Parkinson's folks get very excited about elevated alpha-synuclein. The Alzheimer's field, a little less so. How is that affecting our progression? Is it catalyzing progression? Is it a separate pathology? We are just, more questions are being created as we start to interrogate data sets like BioHermes that are being answered, and that's the wonder of science. So here's the little tease. Within BioHermes1, there's something that I take all the blame. There is something that I have nominated as the MOS 300. If you look at our data set, you will see that there are 300 participants in BioHermes1 across the asymptomatic MCI mild AD cohorts that have absolutely negative amyloid, both on p-tau and on amyloid PET. They have a differentiated diagnosis, though, of dementia or mild AD by experienced PIs using both traditional cognitive scales and the digital scales we used in BioHermes1. By the way, it's called the MOS 300 because our chief science officer is Richard Mose, who's the father of the ADAS-Cog, so you can blame him if you don't like that instrument. And what we have started to look at is what's going on with those 300 that they would have such a clear cognitive impairment across all 3 cohorts and absolutely normal amyloid levels. Check that out. We're starting to dig in there. Interleukin 6, the genomics from our colleague from Wales, it's a completely different aperture into the same set of dementia questions in a group of statistical significance and size that do not have Alzheimer's. We are using that to launch BioHermes2 into more granular approaches to ascertaining both small vessel vascular disease and alpha-synuclein and a number of other things. But we are going to keep the data set open. It will be open to the world in July. Our partnership with ADDI is committed to that. We're eager to have you continue to press the field and attach our data to whatever other data sets you find attractive and important. If we as an organization can help you, please let us know. We're going to be in the UK with BioHermes2 starting next month, maybe May. And if your institutions, if you as researchers have any interest in learning more about that endeavor as we prepare to create that data set, we're happy to share it with you. I think I've exhausted my time, Terry. Thank you all again. A really remarkable performance. I appreciate all your hard work.
Thank you, John. And thank you, John, for not just for the data, but for your support and for pushing us. I think the research community needs push sometimes to work hard, and you and Lynn certainly did that. While the microphone is still live and you can hear it all, I will also want everyone in the room just to recognise Dr. Lynn Hughes, and we'll give her the traditional sign of appreciation also. Okay, we're now going to move on to the science itself, and Donald Lyle is going to introduce our speakers. Donald, over to you.
Hi everybody, how are you doing? I will not rule with the iron fist that was reputed. A curt metronome will be me. Sam, as you might be aware, so Sam is going to be talking to you about an optimized convolutional neural network architecture for ADRD predictive model based on PET brain scans from the Bio-Hermes study cohort.
Hello, and thank you so much for the invite, and really appreciate good to be here. So this is something that we've had opportunity to use the BioHermes data to sort of test basically. So the idea is we want to see whether we can support radiologists to analyze brain scans quickly, using AI. So I'm here with Dr. Ibrahim, who is a colleague of mine and is part of the computational brain health group that we are currently setting up in Sunderland. Okay. So basically that's the outline of the talk. I'll go through the background. So we all know that AI-based approaches is really common now. I mean, we are using it to support, predicting ADRD from brain scans, mostly focused on, MRI data. But recently, we have seen also people applying that to PET brain scans as well. But there's an interesting challenge because of the differences in sort of in terms of structure. The problem has been lack of generalizability of the AI models, and because most of the models are trained on homogeneous datasets and limited sample size. And to be able to generalize properly, you have to train the model using heterogeneous data. And that is what BioHermes data provides. So we took inspiration from previous work which we published last year. We developed some neural network based on the EPA dataset. And we were happy with the performance. So we thought that we could see how these models will perform on BioHermes data. So this is sort of the process. So we took some data from, so BioHermes data. We did some labeling, and then we'll call resizing to standardize the scans because they were scanned across different sites. We did what we call feature extraction based on entropy, which I'll explain in a moment. We went through the development, architecture configurations, training the model, and performing some hyper-tuning. So you can think about it like maybe knobs and trying to tune them. And then we did evaluation to see which of the models really perform. So just a high-level introduction to CNN that is basically modeled around how our brain works. So it's kind of, we have input, so it could be anything from visual to text to anything, runs through layers of neurons within the model, and then we assemble it. We call it max pooling. So assembling the data whilst we go through the neurons, and then we assemble them again to try to make sense out of it, and then eventually we predict what we see, the patterns that we see in the data. So basically, we got the Bio-Hermes data, thankfully, and we kind of extracted those that have imaging. So we got about 945, and that's the demographic distribution. So mean age is 72. And one of the great things about Bio-Hermes is the underrepresented population, which that has been one of the major challenges with dementia data sets. So we started with identifying the images. So we have to resize them, standardize them in a way so that it will be uniform for the model. And then we sort of label them because they've not been through the radiological reviews. So we had to use, medical history, which is one of the clinical data sets in the Bio-Hermes data. So we had to extract those that have been diagnosed to have MCI and AD as well. And then all those that didn't have those diagnoses, we consider them to be normal, cognitively normal. So you can see from here, having labeled them, we see, visually we can see some differences in the data, the images. So we then fed this into the model. But before we fed into the model, even though it's very easy for we humans to be able to, with the expertise, you can easily identify whether this is MCI, this is. So that's what a typical radiologist would do. So we try to mimic that. Even though we have so many scans, there are some that have poor quality, so you cannot make any sense out of it. So we need to find a very data-driven way of doing that. So it happens that there's a very old method that is channel entropy, which enables you to extract information from data. So it's typical images. So we did that, and you can see from your that if you index or if you rank the values that you extract from the image, you'll be able to see those that have good information. So on your right, we see that those have higher entropy values. So we extract that, and then we sort of obtain the top 30 sort of slices. So that's what we used to train the model. And we then started training the model. We have different architecture, different configurations. So the first one, called model 1, has 2 blocks. So we have the images going through 2 blocks. One block is convolutional layer with activation function, which is one of the dials, and then max pooling. So you put those 2 together, and then you can have the MCI. So that's one of the configurations. We try another configuration using three blocks of layers. So the more blocks you have, the deeper the network in terms of neurons that for the architecture. So we then did another model, which is the third model, and you have 4 blocks. So same configuration, but 4 of them all together. So which means that this is more complex compared to model 1. So we then sort of train the model to see how, and then evaluate the results. It turns out that they all perform really, really well. You can see that. So the training and the validation basically shows the difference between splitting the data 80% and the 20% for testing. So the blue line is for the training, and then the other line is for testing. And they also wanted to see how it performs across. So we have epochs. So epochs means rounds of training and learning. And we expect that as you, just like humans, our performance improves with experience. So the same idea as we move across the task, where the models were actually improving. And so this is the ROC curve for the model 1, and we can see that it's performing around 95% across all the cases. If you look at model 2, similar performance, same idea, same pattern. So, and that's what we expected. And that is also, but in terms of performance, model 2 underperforms slightly compared to model 1. And then our final model, which is a model 3, also similar pattern of behavior. You can see that it sort of increases as we go through the various epochs, and also very clear that it's performing well. And if you look at the ROC, it's also around 95%. So all the models tend to perform reasonably well, and you can see that model 1 slightly, outperformed the other models. So this is just a summary of all the models in a snapshot. So this is, and so to conclude, we've observed that we can really model, or we can predict, ADRD from PET scans, and the architecture tend to have impact on the performance of these models. In terms of complexity, it appears that simple models are even relatively much better than complex models, which translates to time of training a model and computing resources that you need and all that. So this is really useful information that we've gathered. However, we think that we need to add more features to the data, including genetics and biological, to be able to see how the models perform. Thank you very much.
So this is a talk from Zoe Kurtzy, who's from the University of Cambridge, and she's going to talk to us today about multimodal AI solutions for early and precise dementia prediction. Zoe, take it away.
Okay, great. Thank you very much. Oh, here we are. Great. Well, huge thank you to everybody. I don't know from where to start. Terry, Kylie, Emmanuel, everybody's been the ADDI folks, Matt and everybody out there, and Lean, Gap, anybody. We were very late comers. This was a DPUK meeting last year where Giovanna introduced me to Lean, and Lean said, what do you do? And I said, oh, we've been building all of these AI models for about 15 years now, before AI was 20. And she said, I've got the right person, you need to meet Terry. And I said, Terry, I just missed the deadline. And she said, don't worry, send it to me over the weekend. So here I am. And it's thanks to a huge team of people that we've made good progress. And so for a long time, really, our work has been looking on how we can predict dementia early. Early also means non-invasively and as least costly as possible. Nobody in their 50s is going to want to have, PET scans if they're healthy or lumbar punctures. Everybody is looking for these less invasive and less costly measures. So the BioHermes dataset has actually been revolutionary for us, and I'll explain why. Now, when we want to look early, what we suffer mostly, and you all know this and we've heard it before, is misdiagnosis. We have up to 30% misdiagnosis, and that's because dementia is not a single disease. We have many different types of dementia. We have comorbidities that look like dementia, but they are not dementia pathology. So how do we separate all of this? On top of this, the difficult thing early on is we don't have sensitive enough tools. For example, even MRI scans that they are approved by NICE as a diagnostic test are very difficult by the naked eye to diagnose from. If you look at this brain, you can see the huge ventricles, the atrophy, it's an Alzheimer's potentially patient. But if you look at these two brains there, it's really hard to tell which one is healthy, which one is the MCI patient brain. So For us, what we realized through a lot of work all of these years is actually that if we were to be able to predict dementia as early and push that kind of boundary, push that envelope, we need to bring many different data types together. And so we've been building these multimodal AI systems that are trained agents that learn from not only a lot of data, but also from different types of data. And so I won't have time to take you through the whole architecture, but the main principles is, first, we're looking at biologically relevant data. So we extract features. We go through kind of a feature engineering approach where we extract features that are relevant for the disease. They are clinically relevant. They predict cognitive decline. Then we go on to look, how we can create a space where the models have learned associations and they allow us to predict reliably and robustly. And finally, we move into a trajectory modeling approach because we don't want to generate yet another diagnosis based on boundaries. What we want to do is to avoid the misdiagnosis, to generate for everybody an individualized prediction. So these models are built to be transparent, to inform us a lot about how they make their predictions. Otherwise, they won't be trusted, they won't be able to be used in clinical practice. So what I show you very quickly here is that we can open the hood and look at each one of these data types that we put in and decide which one is the highest in terms of red color. This is the markers that contribute to the model's prediction the most. We also understand from these models the interaction between different factors, and that is really important because we believe that dementia is not just a one marker disease. As I said, what we do next is from each individual we can extract the score. We built this learned space. We have a prototype for healthy, a prototype for disease, and then any new patient that comes in from a test data set, we ask the question, how close are they in the healthy prototype? And how quickly they move away from the healthy prototype. And what you see here is through a lot of data sets, people that are actually high on this individualized marker that we get from the models are already diagnosed with Alzheimer's. As the marker becomes lower, these are the people that are healthy. And really interesting, we apply to pre-symptomatic data. These are healthy people, no symptoms. You can see some of them fall within the stable kind of area, but some of them are already in the slowly progressive region based on these model predictions. These are the people we need to be watching for. These are the people to go into clinical trials. We don't want people that are rapidly progressive when our clinical trial targets are actually for early intervention. So when we have these scores, what we can do is you look at the MRI scans. These are two patients. The MRI scans look very similar. These are early. One of these patients is in the green. They're stable. One is in the red. They are rapidly progressive. We've done a lot of longitudinal validation. We get the models to predict at time 0 at the first assessment of the patients. We open longitudinal data, and that's why we really need BioHermes2, a little plug-in here. We can then validate the predictions of the model, and you see the standard of care, which is clinical diagnosis, will give us a decline, about 11%, people will then get from MCI to AD, but it's very different when we look at our models. If anything, in this sample, 50% of the people remain stable. We really need to know this. These people should not go into having diagnostic tests that they are invasive, they are costly, should not be going into clinical trials. They have symptoms, but maybe they have depression, maybe they have anxiety, maybe they have cardiovascular disease. They should go down a different clinical pathway. So BioHermes, why is BioHermes so important? Because it brings all of these different data sets together with invasive, for example, PET scans that have been the standard so far, but also all of the blood marker data and the rich cognition. And so here's what we did in BioHermes. I won't go into the details. We put in blood markers, we put in cognitive tests, we put in amyloid PET, and our idea was, how can we push these models to make predictions with the least invasive data? What you see here is the space, the learned space of the model. And if you look carefully, this is when the model separates cognitive normal from probable AD. What you see is, look at the red, right? The ones that are red, these are the markers that contribute the most, and their interactions are what drives the model's prediction. And you see quite similar when the model separates MCI versus AD, but also if you look a little bit at the small print, some other markers maybe differ. For example, NFL versus versus GFAP. Some are a little bit different cognitive scores. This is really important, and will be even more important when we look at different subtypes of dementia that might be actually more, we might have different combinations of markers that are more predictive, right? And therefore, we should be aligning our treatments to those. So what happens when you look at the predictions of the models? You've seen these ROC curves before. These models can get up to 85% accuracy. For us, it's more important whether they generalize, and I'll show you this in a minute. But here, the interesting message is that actually, if you take blood by themselves, and this will be p-tau217 and NFL, and you take cognition, the cognitive test that you saw primarily, it's the Linus and the cognitive view tests. If you take each one of these separately, you don't do as well as putting them together. If you put them together, you get the best performance in your model. If you then add amyloid, you don't get anything more. So your PET scan starts becoming less relevant, let's say. And you can see the green curve there is just the PET scan, the amyloid PET, that does the worst by itself. If you add your p-tau217, NFL, and some of the cognitive tests, you will do the best. Same thing for MCI versus AD. It's a much harder task for the models, right? These are closer to each other. We are still looking how we can improve this, but same idea. Now, as I said, for us, the most important thing is, can these models make predictions for new patients, for new people, right, that they have not been part of the training of the model? And what you see here is exactly this. First, well, I should say that initially we trained the model with a larger set. Then we trained the model with a bit of a more homogeneous sample, and this was all our non-Hispanic white. Yeah. Now we kept out some people from the non-Hispanic white, and we gave that to the model, and the model gives us this multimodal score that tells us how far each new patient is from stable, healthy, and how quickly they progress. The larger the score, the further away they are from health, and the faster they are moving towards AD. And that's what you see here. If you look at this and then you open the clinical labels, you see that people that have already been diagnosed with AD are further down the line, right? They are moving faster compared to people that they are healthy. Now, this, you could say, is not surprising because you train the model with people from the same kind of distribution, right? They are new people, right? So what happens when we have Hispanic? You see a very similar pattern. What happens when you see black? A similar pattern. Now, if you look here in the small print again, you will see that these medians are start getting closer, which means we do have difference. And in fact, when we look at here, we see something that is now coming up in research that amyloid, for example, for the blacks, plays a very different role, right? So really interesting still, points here to disentangle. But just in summary, and I don't know whether I went very fast or very slow.
Yeah, fine.
Ah, great, yeah. Great. So just in summary, what we're building is architecture that they're transparent, so that they can be trusted. We can understand what are the factors that contribute. They are multimodal. They bring in many different data types so that we can understand better the interactions and how they contribute for making predictions to different samples, different ethnic groups in terms of democratizing and diversifying our approach to dementia prediction, but also understanding better what are potentially the different subtypes of dementia that hopefully when we have data, we'll be able to look into it and what are the predictors for these subtypes. So just to summarize, our hope is that moving forward with tools like this, we can make a difference, first of all, in terms of the clinical pathway, but also trials. Who are the people that should be doing the trials? If you have a target that is for early amyloid, for example, antibody, you want people that are earlier in the trajectory. If you have a target for tauopathies, you want people that are later in the trajectory. But also we hope that very much we can go into prevention because these tools can be non-invasive and less costly. So I'd like to close by thanking all my team. This is a wonderful team of computer scientists, clinicians, neuroscientists, cognitive scientists, everybody, and of course, ADDI, the GAP, everybody looking after BioHermes, and all our funders who've trusted me through this journey and given us money to do this work. Thank you.
Everybody. So this is Marco Fernandez. He's going to be talking to you about prediction of PET beta amyloid status from blood proteomics. So Marco, whenever you're ready.
Yeah, as you're already seeing, I'm not Victor. So Victor is the postdoc that was performing the work. So the idea, so the research question behind our work is, because PET scans are most usually on the research setting. Yeah, it's been kind of adopted, but obviously not any kind of healthcare system can adapt them really kind of in a quick way, as you would like. So for us, it would be ideal to have some kind of marker. In this case, we are using for BioHermes like the proteomic data set that is from like SummerScan, formerly known as kind of SummerLogic. They use assays from aptamers. This array version is like 7,000 aptamers that are roughly to 600 something unique proteins. So measuring plasma blood, and you try to relate with these with brain PET amyloid status. So amyloid status here because you just decompress the variable, so it become like binomial to make like easier our exercise on modeling. And so the idea just to pick up earlier detection of Alzheimer's disease. So quickly, so overall, obviously using the ADI platform from the BioHermes data. And then, so the PET was from the company, Mexico. So and then so here that is missing, like, is the threshold that is very relevant actually, and you see a lot of literature trying to figure out what is the ideal threshold for doing this. I don't want to be completely incorrect here, but I think it's 1.3 that uses, so above 1.3 you deem as a kind of a positive for amyloid PET status, and health will be like negative. So, and then for the SummerScan bits, so you have like some kind of preference QC step that's needed for kind of batch correction because you have multiple sites. I believe it's 16 or 17. I think I put 17, I'm not sure now. So what they did is actually, for example, refitting like a linear model several times to each protein and just getting like the residuals. Why is that? There's like other options, but this was like kind of a quicker and optimize it for doing this. And then you have like the outcomes that you're trying to figure out. So one of his outcomes is like just taking PET positive against negative, and then obviously the two levels like probable Alzheimer's disease against cognitive normal and probable Alzheimer's disease against non-cognitive impairment. And then you just use it like, instead of using kind of a frequency kind of approach, Victor was more keen to use like a Bayesian classifier, multivariate classifier, because the size multiple number of predictors from the proteins, and just with the sampling of, in this case, using a Hamiltonian sampling. So in this case, not using like the chains that normally you use because it's super heavy computationally. So that was actually smart from my side to use that. And so in this case, 10,000. And then for model comparison, you just use like a baseline. So baseline is like without any kind of proteins, so just based on demographic and a set of clinical variables plus a genetic one, so the variant E4 for APOE, and then just compare with the full model. So the full model with the proteins plus the baseline one. And then, obviously derived from these like a set of metrics for performance. And on top of this, it's not very common to see like a Bayesian framework plus with a kind of a cross-validation. This was kind of my fault because I'm more keen to use like other kind of models. So I mentioned him to just use that. And obviously it was taking more time to generate like a final model, but in matters of confidence, it's more kind of interesting that you can find that. And obviously, it's generally like because it's a binomial kind of classification. So you have a higher in the curve metrics there. And then ranking these, that's the good thing of using like a Bayesian classifier is because then ranking the features, like the proteins that are more relevant, becomes like similar like a general linear model, right? Because you have beta coefficients that are similar in the interpretation. So like in this case, you get like log odds, and then with that you do some kind of ontology. So ontology analysis is what is the function associated with those proteins. So which kind of biological pathways are associated with your hits. It's kind of interesting to understand a bit the mechanism inside of your model. So roughly, I'm not sure, because always you're just trying to shrink everything. So this is just the core description, the general. You have seen this like in the past. So in this case, we're just certified by our kind of main outcomes of interest. So beta positive and negative. plus obviously you have like total, and then what you do is just have like the demographics, the basic ones, yeah, and you just test for the kind of differences. And if it's like a kind of a continuous variable, in this case, the default one test was like equal sum rank sum, and then for categorical data, compare like different kind of levels within the categories, like chi-square test, for instance. And you see, for instance, for the demographics, yeah, most of the stuff is like, as shown here before, is like age is one of them, and then probably for, I'm not sure if this, oh no, it's from the other one. So, and then for the diagnosis, if you do the same kind of rationale, yeah, you get obviously differences on the diagnosis side when you compare it certified by the PET amyloid beta side status. And then you have like a set, you just try to minimize the number of comorbidities because you have a lot of ones that you could pick up. So vascular disease was one of them, hypertension and diabetes, either type 1 and 2, I would guess here for the aggregation of data. And yeah, again, trying to summarize the statistics and see if any kind of difference between the two groups seems that you don't have anything. And then for the genetic risk factor, yeah, just the same kind of rationale is like just comparing the two groups, and you see that there's like actually a difference here. So why you do this? You do this through trying to figure out which kind of predictors you should include in the model, because when you try to do some kind of data-driven approach, it's useful to know these, unless you need to like check the literature for the relevant outcome that you're testing. And then yeah, for cognition, yeah, you have like NMC score, right? So one of the initial results, yeah, we're going to see a lot of operating curves. Yeah, Victor likes that a lot. So for these Bayesian logistic regression, so you're going to have like a red baseline and the full model blue. And so you already see for these just comparing like positive against negative, you see that the baseline model is not too bad actually. So just with age, sex, education years, APOE status, race, ethnicity, and the three kind of most relevant comorbidities, vascular, hypertension, diabetes, yeah, it's kind of separates, discriminates well the two classes that you see here. But on top, if you just have the proteins from SummerScan, you just get an increment, obviously. And then obviously I will just present the training tests, but the final kind of metric that you should take is always from the testing, the testing sets that you have. So in this case, it will be because you use a 90 to 10% split, so probably it would be like based on the total, probably 93 patients that you have there. Yeah. So the other bit is obviously trying to use diagnosis as well to see. This doesn't come as a kind of a novelty because that is the end of section. So a lot of people already compare these with different models, actually to see that actually the metrics are comparable for some. If you do some kind of meta-analysis on top of that, I think you see that are kind of steady. So for instance, just on the right-hand side, you have like with probable Alzheimer's disease with cognitive normal. You see, for instance, let's just compare the tests. You see that the difference between the baseline and the full model is not a lot. Yeah, but then here for MCI is more kind of conservative the way. So the model is so good as the initial one for the PET status. Yeah. So one thing that I mentioned is the interpretability of the coefficients that you get. So it's very, the way that you interpret this would be like the traditional frequency like approach, right? So for instance, I'm just going to highlight the complex SIM2, that is this one. You see that is positive associated with amyloid PET, positive, right? So it seems that is increased. And on the other side, you have, I think, is a neuropentantic SIM, something like that. So our position is like negative associated with the PET positive status. And then what you do with that? So normally, because these gene symbols for a lot of people doesn't mean anything, right? Because it depends on the fields. So you try to do some kind of ontology on top of that. So right now, I'm just comparing, for example, so A is like from the PET, A, B, and C are respectively from mild cognitive impairment, probable Alzheimer's disease against mild cognitive impairment, and probable Alzheimer's disease against cognitive normal. So you see, actually, that is the funny. If you're just trying to look up, if you can, because this is ranked in the proper order. So it means, for example, if the coefficient is really close to 0, it's not really meaningful to the model at all. But you see that, for example, the tick width of the bands are like the credible intervals here, and probably is not the position that idea. But for instance, this one that is very thin is like the full credible intervals, and this is like the means that you have in the coefficients. And if you just compare the complex scene across the different ones, and you see that it pops up here, right? So it means probably that this marker is more for disease onset. Rather than disease progression. So it's always something. Yeah, so now you just take your kind of ranked input. So in this case, I think it was roughly 20 markers, and try to just match to existing biological processes that we know are in advance. So the genes or proteins that are associated plus the pathways, right? And you do some kind of enrichment now. So this is kind of coming from kind of a hypergeometry test or binomial test. And you just have the p-value, and then just reading the ones that are popping up. So again, for instance, if you just go into this one, so it seems the complexity tool is a membership of the synaptic transmission. So synaptic dysfunction, so is heavy on that one. And then for the sake of just comparison as a kind of quality control, you can, for instance, so this database just goes to the literature and just collates information of previous like associations. For instance, like imagine a proteome dataset that said I found association with neuropentatrypsin before using, for example, brain ischemia. So it's going to use that information to make like a database. So it means that we don't need to search across all the literature. So that's the goal of having a database altogether, right? So one of the top ones is actually related with brain ischemia. I'm not sure like clinical meaning of this, but it's kind of interesting to observe that. So in summary, what our findings demonstrate is that using plasma proteomics could be used like as a kind of a proxy for like PET scans for predicting beta amyloid. So with a kind of we can consider like a kind of crude performance because it's 0.85. And then you just as a kind of ranked like molecules, proteins, you found that like complexin 2 and the neuropentrixin receptor as a kind of markers for amyloid status, which if you just look up quickly, as I did, like a very kind of deep research using Google. I'm joking on that side. So, but looking, seems that they are previously mentioned twice, this complexin 2 with synaptic function. But two of the studies actually were like with animal models, so preclinical. And yeah, and seems that is like related with like onset of the AD pathogen rather than actual progression, as I showed before. So yeah, as for the clinical status, yeah, all the scores are particular for the probable Alzheimer's disease, mild cognitive impairment are really kind of modest. Yeah, it's not very kind of useful at all. Yeah, but seems that using this kind of plasma proteomics could be quite useful in the future for to try as a kind of a proxy tool. Yeah, for I'm predicting beta protein. Yeah, that's it. Yeah.
Thank you so much to all of our speakers for keeping so excellent this time. So I'm going to invite up the Data Challenge team who are going to talk to you about various bits and bobs.
Hey, various bits and bobs coming up. I guess we're at that stage of the day when we're all feeling a bit reflective, so this is going to be a partly reflective piece. We're also at that stage of the day when you're all a bit tired. So what I've done is I've peppered my 5 minutes with loads of pop culture references from the 80s and 90s, so even if you don't want to listen to the talk, you can just see if you recognise the films and the bands. So, we're at the end. Only, not quite then, we're at the end of the science, but we're not quite at the end of the day. We've got some other stuff coming up. In the next 10 minutes, or longer if I waffle on, we're going to give out some prizes. Now, Callie's going to do the prize presentation. I have in my hand the prize winners. It's all very exciting. I have to just say a huge thank you to the AD Data Initiative and to GAP for funding one of our prizes, which is for a team to travel to Toronto to the AAIC. Very good prize. I also have to thank myself, because through the Brain Health Arc, we're going to fund people to come to our SDRC conference in Edinburgh, and we're going to give them a speaker presentation as well, so they can share their science with another audience. So we have that coming up. We also have a bit of work for everyone in the room, for those who want to stay. We want to get your opinions, we want to get your feedback, and we have 2 questions that we're interested in. If we're going to have another data challenge, spoiler we are, what should that look like? How should that work? What data sets should we use? For cohorts that are collecting data, what other data do we need? And I will just tell you that there's still the opportunity within BioHermes2 to add variables. So we're particularly interested in your opinions for those who have worked with BioHermes1. What was missing? What would you like to see in BioHermes2? So back in this room, we're going to have 2 different moderated discussions. Some scribes will take notes and we'll make a summary of that. So you can start thinking already about which of those discussions you want to be part of and what your thoughts are. But it's not the end. Data Challenge Team 1 are disbanding. They're going back to their day jobs. But I'm putting the band back together. There will be a Data Challenge 2. I can confirm that now. I can confirm through funding from the RF McDonald Trust that we're going to have a Data Challenge 2. And I can tell you that in that Data Challenge 2, we have listened to the community. We've listened to what they said about our first Data Challenge. They said things like, BioHermes is fantastic, but it's cross-sectional. Could we have longitudinal data? So I've got a longitudinal data set for you. Very biomedical. Could we have something more in the social care space? So through an awful lot of work in the background, I've actually collated, I think, 10 data sets that have social care data. People said they wanted more cognitive test data. I've got that for you. I've got a data set. People said they wanted more neuroimaging. Wait till you see our neuroimaging data set. I can't confirm them all right now, but believe me, they're coming. And hot off the press, Race Against Dementia are also going to co-fund this, which allows me to do something even more ambitious than I had before. So a huge thank you to Molly and the team from Race Against Dementia. If you want to find out about this, or anything else that's happening in the Scottish dementia ecosystem, I'm putting the URL up again. Please do get onto our mailing list, and we'll tell you about all of our meetings, all of our webinars, all of our training, all of our seed funding, and all the other things we do to support the community. I sometimes have delusions of adequacy, and I kind of think of this being on stage like being in a band, and if this was a gig, this is the bit at the end of the gig where you start to introduce all the different band members. So that's what I'm going to do, and I have to start by introducing the people that made it happen, the people that had the idea, the people that provided the data and the infrastructure, GAP and the AD Data Initiative. You've heard from them before, they're so instrumental. Let's give them a round of applause again, please. On drums, I have to give a big shout out to the people that funded this. Race Against Dementia funded this first data challenge with also support from the Scottish Funding Council through the ARC. But we also had a huge amount of in-kind support from Synapse, from University of St Andrews, from University of Glasgow, and lots of other people, too many to even fit on a slide. So let's give a round of applause for all of these people. But the data challenge was all about people. And one thing that was very important to me when we started was it wasn't to be a University of Glasgow gig, it wasn't to be a University of Edinburgh gig, it was really to be pan-Scotland. And so we teamed up with the University of St Andrews. You've heard Marco speak. Victor was very important, Paul was very important as well. Working with some of you in the room, helping us understand the data at the start. Let's give them all a round of applause. And here's the home team, the Glasgow team. I needed a statistician. I heard about this brilliant statistician called Stelios. I got him on the team and he's been fantastic. I know a number of you have worked with him. The data challenge only worked because we got the message out there and there's a huge publicity push. So for that I have to thank Millie, our comms officer. And these meetings don't just happen out of the blue. They require a huge amount of organisation, military precision, and we have to thank Sheena for that. So round of applause for Stelios, Millie and Sheena. If this was a rock gig, this is the point where I would lift my imaginary cup and I would say the other member of the band is all of you guys. But it's absolutely true. This wouldn't have happened unless you had engaged with Data Challenge 1. I know all of you did this as a bit of a side hustle on top of the other things you do. So I'm incredibly grateful for everything you've done. Give yourself a round of applause. And that's it. I don't think there's anyone else in the team, is there? There's one more person. Of course, there's one more person. The person you all know. The person who, if I'm being honest, did all the work and actually made this happen. I was just in the background taking the glory. Callie, please come on stage. So, I can tell you a true story, and this isn't to make Callie blush. When we interviewed, at the end of the interview when Callie left the room, the other interviewer and I just looked at each other and went, wow. And we've been saying wow ever since.
I didn't know the story.
So, thank you very much, Callie. I think it's over to you now.
Thank you, Terry.
In my hand are the winners, Oscar style, in an envelope.
Thank you. Well, all the winners are going to have to wait because I want to take a look back at what we did. I don't think I'm so sorry. You are going to have to wait just a few more minutes because I don't want us to understate how huge what we have done and we're closing today is. John said it so well. I don't claim to be able to say that better than he did. Terry iterated this very well from the researcher perspective, but I do want to look back at where we started. We wanted to democratize data access. You heard earlier from other speakers, you heard from Simon Young, you heard from Will Whitley about existing data sets, how they can be linked, how they can be accessed and used. But there remain barriers. The speed with which we reach them matters a lot. You heard from John. Dementia is progressing really fast, and we are always behind. You saw in my slides earlier, the one figure, that the oldest things we know about measuring, predicting risk of developing dementia are actually the least well-performing ones. What does that tell us? That tells us that perhaps a lot of what we know, and we think we know because we have evidenced it many times in the past, might just not be relevant anymore. So we need to be moving fast. And not only do we need to be moving fast, but also we need to be including all the people whose ideas can bring research forward. That doesn't just include people who know how to work with big data, and it also doesn't just include clinicians or people with the right background, that knowledge about the specific cytokines, for example, that I would never claim to know anything about. But if not for bringing people together, we would not be able to actually drive the new ideas, move forward, find out new things. So we wanted to try and address some of those barriers, and that's what makes the challenge unique. You've probably seen this before. We reached over 40 teams. That's over 100 individual researchers across 29 locations and 18 locations, in 29 institutions. That is not a small number, considering we started here in Glasgow. And I won't bother naming the institutions because I think the map speaks for itself. But I do want to note that we reached researchers at so many different career stages. We reached PhD students, we reached professors, we reached clinicians, and we made sure that every single team had an equality, diversity, and inclusion consideration in their project, whether that was in the analysis and designing how they would account for demographics in their results, or in the team makeup. And not only that, but we managed to bring together teams where we saw potential for collaboration, and we managed to both promote and also create groups that were collaborative across disciplines and institutions. That is huge. We spoke about, Terry always talks about silos, how a lot of research, and especially about health research, is in silos. We're all working in our little bubbles, and we have expert facilities here and expert facilities there. But if we're not coming together, we're not moving fast enough. So we brought people together. And then we made it super easy for everyone to access the data set. This is all the documentation that the 22 successful projects had to complete. I'll say this again, 9 pages, 6 to apply, which is a very manageable workload to summarize your research question and come to us. And mind you, we also stated that we were accepting ideas that were not fully formulated yet. So we actually brought in teams, and we only asked them to fill out those 6 pages. And the 22 successful projects then also signed this 3-page agreement. Now, why? How did this happen? Because Terry and Dr. Hughes and me, we did the work of the background stuff. We got the ethical approval. We screened the project applications. We brought together a panel. We worked with researchers funded by Race Against Dementia. We brought together researchers from Synapse, from networks like Scottish Dementia Researcher Consortium. We made sure that we gave the panels a chance to veto applications, and we made sure that we included the right projects with the right questions that were fitting for the data set. Basically, this is what an ethical committee would do. We then made sure that everybody understood their responsibilities to protect the data set for our data grantors and the identities of the participants in it. We made sure that everyone understood what that meant. In simple terms, 3 pages. That's it. That's it. And we got everyone as fast as possible on the workspaces. But that's not all we did, and I think this is the biggest novelty of this effort. We supported the data work. I mentioned that we want to be bringing people together, where with the data background, with the theoretical background, and I mean it. There were a lot of teams with the perfect ideas, but perhaps not the expertise to perform them, or without the resource to use their expertise to perform their analyses, or without the knowledge of the specific software they would need to use according to the platform. These are not small considerations. These can be the roadblocks that can stop an actual important learning about dementia research from ever being shared with the world. And we addressed that. These are just some of the things we did. I'll use I here. I created a narrative summary to make sure that every single researcher that was working with the data set knew the important things they needed to know about the people in the data set, the structure of the data set and how it was collected, and therefore how they should interpret their results accordingly. I also created a roadmap, I call it. It's like a bird's eye view of the data set. I mentioned earlier in my slides that this is an expansive data set, and the multimodality of it is a huge consideration. The fact that there's multiple measures per participant, per site, per type of testing is a huge barrier for researchers with the right ideas, but without the expertise and the experience of working with data sets of this size. Not to mention this number of people involved included in this data set. So I created these resources, and I worked with my teammates, Stelios, Victor, and Marco, and with the help of Paul, and we created more instructions to make sure that everyone was able to understand how to use a data set. Where they could not do that, we provided project-specific support. Hands-on. You heard from some projects that we analyzed. You heard our names. You heard Victor mention, Marco, myself. So I hope that by now you can understand that this is really a unique effort, and there's nothing like it to date. So this was our achievement within 1 year. 22 unique learnings about dementia. That is not a small number, and all of those results only happened because we took on the burden and we let researchers focus on what they do best. So, having said that, now it's time to think about your achievements. So, let's talk about the winners of the prizes. So, we will start with the winners who are very kindly sponsored by the Brain Health Arc. To attend the Scottish Dementia Research Consortium in Edinburgh, 6 to 7 May 2025. So I genuinely don't know what's in here, so bear with me. So we couldn't decide on 2, so we went for 3. So prize A goes to Katie Burdett. Do you want to come on, Katie? Congratulations. Katie brought to us a poster.
Yes.
I didn't have the chance to listen to your presentation. I'm really sorry about that. But I did work with you before you brought this.
Thank you for that. Yeah. It's massively helpful. She was right on call. We had lots of chats. So yeah, once again, big Callie fan. Thank you.
Thank you, Katie. Well, congratulations. Our next prize winner are, well, one of them's not in the room. Connor and Austin. Austin, do you want to come and accept the prize? So I'm so glad to see this effort awarded. It's been wonderful working together. Congratulations.
Thank you.
And Connor, I hope you're watching. Congratulations to you too. You're going to Scottish Dementia Research Consortium. Thank you. And congratulations. And now we have our third prize winner, who is Angelina Cantova. Congratulations.
Thanks, Kylie. Again, kudos to Kylie and the team. Another round of applause, please.
Thank you. That's very kind. Congratulations. So, to recap, to the Scottish Dementia Research Consortium in Edinburgh this May, the Brain Health Arc is sponsoring Katie Burdett, Connor Dalby, Austin John Dibble, and Angelina Cantova. Congratulations. And last one. Let's look at the award to the Alzheimer's Association International Conference in Toronto this July. This is sponsored by Alzheimer's Disease Data Initiative and Global Alzheimer's Platform. This is a very generous gift, so thank you to our partners for gifting this. So, it says prize 3, it's you, Callie, of course. Proud of you. Is this serious? Yeah.
When the board starts thinking facts, I should tell you a little bit about how this was judged. It was judged on the criteria that we set the challenge on. It was judged on the novelty of the idea. It was judged on the spirit of collaboration. And it was judged on the quality of the science. And it wasn't me that made, I'm very happy with